Dr. Bire, welcome.
Thanks, Dr. Kihara. I didn't get you quite clearly, but I believe that you've welcomed me, so I can proceed.
Yes, please.
Oh, thank you. As Dr. Kihara has rightly introduced me, Dr. Sylvanus Wagwira is my name, based at the Kenyatta National Hospital, a neurophysician. Of course, I come in this topic of today because I have a lot of interest in epilepsy. Of course, that stretches to non-epileptic seizures too. Now, it is indeed a great pleasure to be part of this non-communicable disease symposium. Today we are discussing epilepsy, and of course, epilepsy is becoming pretty common. One of the reasons, of course, being a lot of accidents that we see, motorbike accidents. Now that we are having motorbikes as one of the leading transport mechanism. Now, mine is quite brief, and just to introduce the speakers, we have 3 speakers lined up this afternoon, and just a brief housekeeping that will address all the questions at the end of the 3 talks. We are hoping that will be done by about 3:30, so then we can probably have adequate time to respond to as many questions as will be possible. Now, to increase chance of your question being responded to, we are encouraged to post it in the Q&A box. Now, without further ado, I take this opportunity to introduce our first speaker. Our first speaker is Dr. Judith Kwasa. Dr. Judith Kwasa is quite well known in these circles, having given so many presentations on this topic. She's a consultant neurophysician, and she's a lecturer at the University of Nairobi, where she's been for the last over 10 years. She also runs a general neurology clinic. Dr. Judith has interest in epilepsy, which quite stretches back to the days of her postgraduate studies, where her dissertation was on bone health in women living with epilepsy. And of course, from my interaction with her, I've seen that she has quite a passion with in the field of epilepsy, especially in women. Dr. Kwasa's other neurology interests lie in headache, movement disorders, demyelinating diseases, cognitive disorders, and neuroinfections, which obviously is an area which you cannot afford to do without in this part of the world, the tropical part of the world. So without further ado, again, Dr. Judith, you're welcome to give us your presentation.
Thank you very much, Dr. Wire, for that very kind introduction. Thank you also, Dr. Kihara, for getting us started on this. And I hope in the next probably 25, 30 minutes to give us what might be a quick overview of epilepsy. And I chose to do this in terms of a case-based presentation, because maybe that will help us think through this different things that we meet when we are dealing with our epilepsy patients. And I understand today's audience is quite diverse. Some people who directly are managing these patients, some people who might not be directly managing them, but have an interest. And some of us just maybe with our loved ones who are also people living with epilepsy. So this is a brief outline of what I will be going through over the next 25 to 30 minutes. And we'll go right ahead. So this is a gentleman, PK, I met in 2017, July. And at the time he came to see me, I was seeing him in a private clinic. He had complained of experiencing episodes where he smells a horrible smell. And it really distressed him to the point where he'd be asking, his loved ones or the people he was with, can you smell that? And for some reason they couldn't. And he described it as a burning smell, and it was putrid. And he said it would last for about 1 to 2 minutes. He'd experience a little bit of dizziness. He'd feel a little off balance, and then it would disappear. And sure enough, none of his friends would have smelt it. So over the previous 6 weeks, he had experienced 3 episodes of this, but there was no accompanying headache with that. He had no automatic rheumatisms, but he did have a very significant past medical history. He had been involved in an accident in 1995 where he did lose consciousness, and we just probably thought it would be a moderate traumatic brain injury, and then a repeat injury to his head in 2016, this time as he was assaulted by thugs. So he had not really been a lucky person. He also had an important social component to his life. He had started off with small volumes of alcohol, but had over time, I would say, escalated to what we can describe as an alcohol use disorder. He would have to have at least a quarter, and as we know, that's about 250 mils of spirits on a daily basis. There was no family history of seizures. An examination was notable for a right-sided facial scar, which was obtained during the assault in 2016. And he also had a trauma-induced right enophthalmos, so his right eye seemed much smaller than his left. He had come in already having done an EEG, which was reported as normal. He had also gone ahead and done a CT scan of his brain, which showed some mild cerebral and cerebellar atrophy. So at that time, the impression I made just listening to this gentleman and listening to his significant past medical history was that this was probably a focal seizure with an aura, okay? And it probably did have a temporal lobe origin, just going by the fact that he was experiencing olfactory hallucinations prior to, as part of that presentation. So because of this, and we do know that the CT scan, even though it's a very useful thing, might not be able to pick out a lot of detail, we did go ahead and do an MRI of his brain, which coincided with a right temporal gliosis, which we thought was probably the origin of his seizures. And he had a normal hippocampus, which is important when you're dealing with epilepsy. At this time, I think he declined the medications, probably for reasons best known to himself. I imagine he must have been processing a lot of information and thinking that, does this mean I have epilepsy? Does it not? So he declined to start on medication, which is really well within his right. So 2 months later, he comes in, and the reason he comes in is because this time the horrible smell had actually proceeded into a generalized tonic-clonic seizure. He had been assisted by his friends and family and then taken him to a local facility, which was not Kenyatta Hospital at that time. I can't remember which one, but he was started on phenobarbital. So he had come in to see me really to see, is there more? I need to hear more about this, because the last time we talked, I wasn't too happy about starting drugs. So he wasn't happy with his phenobarbital. And because of that, he said it was making him very drowsy. He could barely function. He is what we nowadays call hustlers. Basically, he was a businessman dealing a bit in real estate and supplies. So he really needed to function. I transitioned him at that time to carbamazepine and started him on the controlled release formulation, which was 200 milligrams at night. Now, I will mention again that this is a gentleman who has a lot going on, including an alcohol use disorder. And so you'll notice there are great gaps in his presentation because, quite frankly, he's lost to follow up. So he comes in almost 9 months down the line. He informs me that he stopped his medications in January, which was about 3 months after we had started them. He felt like the carbamazepine was really intolerable. He wasn't able to work. And the reason he had come in May was because he was having uncontrolled seizures, almost seizures every week. And he had had, unfortunately, a lot of injuries with these seizures. So at this time, considering he felt like 2 drugs had been intolerable, we transitioned him to levetiracetam. And we also gave him very useful lifestyle advice regarding ethanol cessation and the importance of adherence. So how did he do? Well, not so well, because the first month he would experience at least 1 or 2 seizures, which is down from every day or every week, is an improvement, but we can do better. They were mostly generalized tonic-clonic. They had several olfactory auras, and we escalated his levetiracetam because of that. In July, which is 2 months down the line, he experienced a cluster of seizures, which is very concerning, especially when you're managing patients with epilepsy, because it predisposes you to status epilepticus, which is a medical emergency and has a pretty high fatality rate. On evaluation, trying to figure out why is he not doing so well, we did find that he had a very low sodium at 126, whereas the rest of his electrolytes were largely normal, and he did still have a very significant alcohol intake. for which he thought was not a problem and so was not willing to escalate into rehabilitation. So my question at that time, and we'll probably come back to this, was why did he have that low sodium? Because we definitely feel it was contributing to how his seizures were controlled, and how could we have dealt with that? So that was my main question at that point. How can we improve his care? What sort of options do we have? And in order to get us to those answers, we'll just deal a little bit about the background of epilepsy and its classification. So from this slide, you will notice that this is an International League Against Epilepsy definition dating back to 1981. Now, I'm sure a lot of us here might not have been thought of at that point in time, and looking back, that's over 40 years old. But the reason it was so important as it is now is because it was such a useful classification, and we still borrow very heavily from it. So at that time, if we remember from our teaching, those of us in the medical field, you'll remember there were partial seizures and there were generalized seizures. And over time, this has been changed simply to reflect the fact that when we use the term partial, it gives the connotation that it's not quite a real seizure, but it is. And it really, all it means is because a seizure is an electrical phenomenon, all this really connotes is that this is arising from a specific area as opposed to it arising from both hemispheres. So these were really useful terminologies, and we still really borrow quite heavily from this. But in 2017, there was a revision of this classification, and most importantly, we can see the main difference is that we now classify seizures in terms of their origin or where they start. And if we can identify that right down to a particular place, we call that focal onset. Whereas if it seems to arise from both hemispheres at the same time, we call that generalized onset. And I would say most importantly, we acknowledge that in medicine or in epileptology, there is a lot that we don't yet know. So especially with the genetics, that we are now discovering a lot of previous seizure disorders that we thought were not genetically derived actually have some form of mutation associated with them. So under focal onset of what we used to call partial seizures, we'll find things like what we used to call, say, simple partial seizures are now called focal onset seizures with impaired awareness, because the importance of this was we used to consider generalized seizures only as the ones where we lose consciousness. But now we're aware that even though you don't lose consciousness, you might have an element of impaired awareness. So you're still fully conscious, but you're not quite aware of your surrounding, and you might do a lot of purposeless repetitive movement. So we now refer to it in terms of awareness rather than consciousness, and that was important. So what we used to call complex partial seizures might now be called focal onset with impaired awareness. What we would call simple partial seizures would just be called focal onset motor seizures. Of course, there is the element of having non-motor seizures. We've heard of cyclical vomiting, especially in children, which are considered types of seizures, and those would now be called focal onset autonomic seizures. So this was a really important step in reclassification, but I will remind us that we still borrow quite heavily from the 1981 classification. So in terms of classification in epilepsy in 2017, we also went further to define the definition of seizure types and how that translates to epilepsy types, because you could have several seizure types in a specific epilepsy type. You could have a combination of, if we're thinking of juvenile onset or juvenile myoclonic seizures, you could have myoclonic seizures, but you could also have generalized tonic-clonic seizures. So we define the seizure types at the top of this table. We then go ahead to define the epilepsy types. And sometimes we're even able to identify specific patterns over time, and that will give us an epilepsy syndrome like the one we've just talked about, the juvenile myoclonic epilepsy. We also can see from the right of this slide that there is a lot to do with the structural changes that might be in the brain, a heavy component of genetics that is really emerging, infectious background, metabolic changes, immune, and like we said, we are not afraid to say that we might not know things at the current. So how do we evaluate seizures? So if a patient comes in with a possible new onset seizure, I'll take us just to the left side of this screen. If they come in with a new onset seizure, what is most important is, does the event have a description or a witness report? Because I feel like 80% of the diagnosis comes from the witness report or from the description of the event. And if it does sound like a seizure, then we need to go ahead and get a really good history that dates back to the, in young adults, we'll be looking at the perinatal history and their childhood history, looking for older seizures or seizures in their childhood. And then we'd go ahead and perform a physical examination, mostly to look for focal neurological deficits and to examine for any evidence of arrhythmias. If the event description doesn't quite fit a seizure, then we might need to think about other things that can really very much sound like seizures. These would be considered mimics, including things like migraine, transient ischemic attacks, or even syncope. So once we go ahead and perform this physical examination, we next need to look for what we'd call danger signs. So is there evidence of fever, focal deficit, or mental status changes? Because if we have these danger signs, then we must admit this patient and work this patient up quite well. If there's no evidence of these danger signs, fever, mental status changes, or focal deficits, then we need to look for provoking factors that might provoke a seizure. And these would include very common things like sleep deprivation, alcohol, or the use of medications and drugs that could provoke a seizure. So I'll take us to the left side of this now. And if we did have those danger signs, as the table shows, we might need to admit this patient and perform more urgent investigations, including laboratory tests, imaging, and electrophysiology. If the patient didn't have any of the danger signs, then we are able to do a non-urgent evaluation for this, what might be a provoked seizure. And once again, this does include lab testing, imaging, and an outpatient interictal EEG. In terms of management, if it's a single seizure, we would probably advise lifestyle modification, getting adequate sleep, cessation of alcohol, and try to defer the use of anti-epileptic medication. So, supposing we've gone down our workup and we've found that this is actually a seizure, there are no danger signs, and there's no evidence of provoking factors, what do we do then? Well, we want to perform an EEG. We want to also perform an epilepsy protocol, MRI, which would include images on coronal sections, which tell us a lot more about the temporal lobe and the hippocampus, which is a common origin of seizures. And if the results are abnormal, even with this single seizure, then we are justified in starting medication. But if the results are entirely normal, we may defer the anti-epileptic medication, because we do know that if you've had a single seizure, it can be several years before you get another seizure, or you might not get another again. But if you've had 2 seizures, then that risk greatly elevates for the 3rd seizure. And so that's when we start medication. So we've chosen to start medication. We will talk about what sort of medications we can choose, but I did want to take us through what we consider drug-resistant epilepsy. Now, for most seizure patients, they will respond to a single drug. And so the practice is to start low, to choose an appropriate medication for that particular type of seizure or epilepsy, and to slowly escalate the dose, really guided by whether or not this patient is achieving control or not. But sometimes we get a 20% who will not respond to a single medication. And so in that case, we might need to add a second medication. We know from previous studies that only 11% will achieve seizure freedom after failure of one anti-seizure medication or anti-epileptic drug, as I've described as AED on the slide. But if we do 2 drugs and we're still not achieving control, then only 3% will achieve seizure freedom after using 2 drugs. So we define drug resistance epilepsy as the failure of 2 tolerated and appropriate anti-epileptic medication or anti-seizure medication to achieve sustained seizure freedom. Our target in every patient, of course, is to achieve seizure freedom. However, that's a target that in a lot of people is hard to reach. And so we have different definitions for seizure control, which could include anything from a 50% reduction in seizures or up to 1 seizure a month as being tolerable or well controlled. The predictors of what would make these patients not respond to 2 drugs or have drug-resistant epilepsy include a very high seizure frequency, an underlying etiology that either we've been able to identify and not deal with, say, for instance, the alcohol use disorder, or previous traumatic brain injury. Another predictor of drug resistance includes a failure to respond to anti-epileptic drugs early. So epilepsy can be very rewarding to treat in that when we start that first drug, a lot of patients achieve seizure freedom within the first 3 months, and I would say up to 50 to 60%. We can increase this to about 80% after we've escalated that dose to a tolerable and safe amount, and then we have that 20% that might need a second medication. The risk for drug-resistant epilepsy, why is it important, is because we have seizures despite using a lot of drugs, and that puts it at higher risk of sudden unexpected death in epilepsy patients, or SUDEP. It also puts the patient at risk of status epilepticus, which is uncontrolled repeated seizures with no recollection of consciousness, or just a diminished quality of life, which is a huge, huge factor in these patients who are unable to go about their normal life and to make their living and to support their family. So in these patients, epilepsy surgery or neuromodulation, which Dr. Magoha will take us through quite well, has a very big role. And this allows us to locate the epileptogenic zone. We do know seizures come from the cerebral cortex, the covering, the outer layer of the brain. And so we need to locate exactly where it's coming from and see if we can try and in some way ablate that area, or if that's not possible, see if we can stop the communication between both sides of the brain so that we don't end up with a generalized seizures. So this is, I think, borrowed from Dr. Magoha's presentation, which he might not have even known. This just helps us with pre-surgical localization of how to achieve or how to figure out where that seizure might be coming from. And we'd use really, it looks almost simplistically beautiful because we apply a grid phenomenon where we put all these electrodes, the closer to the brain, the better. So in the top left panel, which is panel A, you can see that you've actually have the dural fold and we've attached that grid right to the brain. And in the B panel, you can see on imaging what that grid would look like. And it helps us really localize where this seizure might be coming from in terms of when we do the EEG, because that will also help the surgeon in how best to approach this. So then we move to the medication, because we have said that if you've had more than 1 seizure, you probably need an anti-epileptic drug, or as they are being called now, anti-seizure medication, simply because they don't treat epilepsy, they control seizures. Epilepsy is a tendency to recurrent uncontrolled seizures, and these drugs are really targeting the seizure rather than the epilepsy. So the name, once again, is transitioning to anti-seizure medication. We know our traditional drugs include some of the very widely used drugs like phenobarbital, carbamazepine, phenytoin. Primidone, not so much in our market, but these are considered some of the more traditional drugs, which are very, very useful, much more affordable. But of course, they do have a side effect profile that for some might be intolerable. So oxcarbazepine, topiramate at lower doses, all of these would be considered enzyme inducers. And the importance of this is that when we induce these enzymes in these patients taking these drugs long-term, they have interactions with other drugs because they break down, or they help break down the other drugs a bit faster than expected and reduce the other drugs' efficacy. So a typical example would be if we use these enzyme inducers in a patient with HIV, it might break down their antiretroviral medication much faster than expected. And what that does is it reduces the efficacy of their antiretroviral drugs, which, as you can imagine, would be a disaster in terms of their long-term output. So as we consider these drugs, we need to consider whether they are enzyme inducers or not. Some of the non-enzyme inducers include drugs like valproate, levetiracetam, topiramate at lower doses. Sorry, I meant to put at higher doses, and then lamotrigine. Now, there was a proliferation of newer drugs, anti-seizure medications from around the 2010s upwards. And so there are lots more drugs coming in. And since 2016 alone, there have been at least 3 more FDA-approved drugs, which include brivaracetam, cannabidiol, and stirpental. Now, before we go all happy and say, yes, medical marijuana is with us, I want us to remember that cannabidiol does not share the psychoactive properties of tetracannabidiol. And so we can't smoke weed and expect to treat seizures, because what we will get is less of the benefit and a lot more of the psychoactive component. But it's important to know that people who do smoke marijuana are probably not at increased risk of seizures, as opposed to other drugs, including cocaine and heroin, which does put them at a higher risk for seizures, both from the drug and from the withdrawal of the medication. So we also need to think about what sort of seizures we're treating. And if we have a combination of both focal onset and generalized seizures, then we might want to consider starting a broad spectrum drug. And on the left panel, you can see a list of what would be considered broad spectrum drugs, including some more common drugs that we have in our market: valproate, levetiracetam, clonazepam as well, clobazam, lamotrigine. Those would be considered more broad spectrum, whereas a narrower spectrum would include drugs like phenytoin, carbamazepine, which would be mostly for focal onset seizures, oxcarbazepine, eslicarbazepine, lacosamide, gabapentin, pregabalin. Even though we use them more in pain, are considered anti-seizure medications, but they're not very effective drugs. So a lot of times we won't start patients on the last 2, simply because we have much more effective anti-seizure medications. Now, what about if your patient has other comorbidities? Because a lot of patients, and a lot of times we will have patient with seizures, but they also have, say, alcohol use disorder, or they also have some form of renal or hepatic impairment. So in these patients, we need to consider what drugs would work best for them. And for a patient with hepatic derangement, then the first-line therapy for them would be drugs like levetiracetam, lacosamide, topiramate, gabapentin, pregabalin, less so. The reason these would be considered first-line is because there really is very little hepatic metabolism of these drugs, and so they would probably not worsen their liver function. As you can see from the line, there's some drugs that we would actually try to avoid, and these would include drugs like valproate, phenytoin, phenobarb, and even carbamazepine, just because of the interaction with the liver enzymes. What about if your patient has renal failure? A lot of patients are on dialysis, a lot of patients are diabetic, especially if we think about the adult patients. And so what would help with our choice in medications in these patients? Well, this isn't as simple, because there is no single drug that we can say is most effective in patients with uremia. So we base our choice on the type of seizure, and we must remember to adjust the dose for the estimated glomerular filtration rate. In dialysis patients, not only do we alter the dose, but we also try and time when we're giving those drugs so that we don't end up giving the drug just when the patient is going for dialysis and then the drug is completely washed out of their system. So the options would include things like levetiracetam, lacosamide, and then once again, we'd have to avoid things like phenytoin or valproic acid simply because of the interactions. We need to consider other triggers for poorly controlled seizures in renal patients. And this is especially important because we can get seizures not because our drugs aren't working, but because we have a uremic encephalopathy or we have a dialysis disequilibrium, which can present as a seizure. Alternatively, our metabolites could be a little off, like our patient who had a low sodium, and this might be related to the renal failure. So the seizures in renal failure can be a little more difficult to control, but it's important that we consider all these as we go ahead. Another important aspect of seizure control is epilepsy in women. These are a special group of seizure patients because when they go through their childbearing age, we must consider that they might be on contraception, and we need to choose drugs that will not decrease the efficacy of their contraception. So we try to avoid oral contraceptive drugs in patients who are taking enzyme-inducing medication, and we advise them about their contraception, tell them to avoid hormonal methods, especially estrogen containing, so that they opt for other methods. Progesterone would be preferable in these patients. Once again, we need to consider that they need to supplement their folic acid so that if they do get pregnant, we have reduced risk of teratogenicity. And we also need to consider that these patients might have a reduced fertility. There's the element of around the menses, seizures becoming more common, which a lot of women experience. And that's why sometimes, even though they're really well controlled, they might have one seizure a month. So we need to consider catamenial seizures in women. And lastly, as they approach their sunset years, there's the issue of bone health because they lose the protective effect of estrogen. And we also know that our enzyme-inducing medications can further lower their calcium. So we need to consider that as we start these patients on drugs and their different age groups. So we know for a fact that even in Kenya, despite all our sunlight, we do have evidence of bone metabolism being worsened in patients even before they reach menopause, in women even before they reach menopause. And this was part of what I studied in my postgraduate dissertation. And then there's the whole issue of pregnancy. So pregnancy starts from preconception, from before you get the baby. We need to make sure you have the best choices and the best options. So we supplement your folate before you get pregnant. We avoid drugs that are highly teratogenic. We counsel you and tell you that, no, we're not saying avoid pregnancy. Absolutely not. We do want you to continue with your desired family, but we want to be part of that process. And more importantly, we try to avoid too many drugs at the same time. Once the patient is pregnant, then we must make sure that we are part of that journey, making sure their drug levels are normal, and also taking into consideration that as they go through the 3 trimesters, the drugs will behave differently. So you might find that you need to increase the doses towards the 3rd trimester, and after delivery, bring down the doses simply because of the change in volume of distribution. For delivery, we are aiming for a normal vertex delivery. And if need be, we want to lower the pain threshold so that we don't provoke a seizure. So epidurals are very useful in these patients. We also want to try and encourage them to try and get as much sleep as possible because we do know missed sleep can provoke a seizure. And postpartum, if we had increased the doses in the late stages of their pregnancy, we now need to slowly bring down the dose, which depends on the drug. Some drugs we can taper down quickly, other drugs we can't. We want to encourage these women to breastfeed because breast milk is best. And even if there is some passage of the drug to the baby, it's in minimal quantities. So what are our preferred drugs? From this little table you've seen, lamotrigine and levetiracetam would have the lowest teratogenic profile, whereas if you look to the right, valproic acid would have the highest teratogenicity, so we avoid that in women of childbearing age. We did say that breast milk can transmit some of these drugs. From this table, you can see the percentage is quite small, but even though the breast milk levels may be high, like with levetiracetam, we do know that it translates to a very low infant plasma level. So that means they are rapidly eliminated. Maybe it's God's way of protecting the baby. And so we strongly encourage breastfeeding. So we'll get back to the case as we close. Why did this patient have a low sodium? Because we did strongly feel that this was contributing to the fact that he was having poor seizure control. There are several possibilities. Could it be levetiracetam induced? Could it be from his previous head injury? He's getting a syndrome of inappropriate ADH. Or could it be a dilutional hyponatremia from the fact that he does take a large amount of alcohol? There have been some case studies looking at levetiracetam and hyponatremia. And so we discussed this, but we opted to not switch his medication. We opted to keep it there, but add him a second drug to see if we can probably get benefits. What would be a good drug for him? Carbamazepine, great drug, especially for focal onset seizures, but it and other enzyme inducers can actually worsen the hyponatremia. So that knocks off our carbamazepine and phenytoin. Valproate would be a probably good addition. However, there is the concern that valproic acid can give a lot of weight gain, which might not be manageable in a lot of people. So I think that left us with two options, lamotrigine and lacosamide. Lacosamide is a drug that works very well for focal onset seizures. And so we decided to do two things: replace his sodium slowly over time so that we don't get into complications of rapid replacement, and add lacosamide. And for the first time, he had 8 weeks of seizure freedom, which, as you can imagine, is amazing, considering this is a patient who was having seizures on a weekly basis. A repeat of his sodium was not so encouraging, but it probably meant that the lacosamide was still able to decrease his seizures despite him having a seizure-provocating metabolic defect. So the lacosamide was escalated. Unfortunately, like we said, he did have a lot of other social issues. He weaned himself off his medication. He was counseled and advised on restarting, but unfortunately, I lost this patient to follow-up. I thought he was an interesting case because it just takes you through some of the common, I will say, complications and everyday decisions that you have to make with seizures. So in summary, what are my lessons learned? One is that seizures cannot be handled in isolation. We need to consider the social context. He needs family support. Your patient, we need to consider how much alcohol this patient is using, whether they can actually afford the drugs. It's no use prescribing lacosamide if this patient can't afford lacosamide, or if it's unavailable where you practice. The choice of drugs should be guided by the seizure type. So we did try to pick drugs that work for focal onset seizures. Trust your gut as a practitioner. If things are not working out, maybe there's another reason. It might not be your drug. It might be something we're overlooking. But ultimately, the last decision lies with the patient. The patient is the one to take the drug. So yours is to guide and give the best advice on how this can be done. I want to thank you all for your attention, and I will be happy to answer the questions at the end of this presentation.
Thanks, Dr. Kwasa, for that very clear, precise presentation, especially the case, quite an interesting case, and it does depict day-to-day encounters with the patients with seizures. In the interest of time, we'll keep the questions to the end, and we encourage you to keep on posting questions in the Q&A box. We want to move on quite quickly to our next presentation, and our next presenter is Dr. Michael Magoha. Dr. Michael Magoha, just briefly, is a neurological surgeon. He's also a lecturer at the University of Nairobi. His research interests include neuro-oncology, neuroendoscopy, and he does like working with the patients with seizures. He's going to take us through surgical aspects of epilepsy. This is an area that is quite coming up. We probably are not currently doing so much, but I think he's going to share this, and we do get quite a lot of questions. I think this is quite a good follow-up, especially after Dr. Judy has discussed about resistant epilepsy. Dr. Magoha, the floor is yours.
Thank you very much. It's glad to be here, especially coming after such an excellent presentation. I wanted to say we also have started the first epilepsy monitoring unit in the country, has started at the Aga Khan. So we're moving towards doing a lot of these surgeries.
Greetings, everyone. My name is Dr. Michael Magoha. I'm a consultant neurological surgeon and lecturer at the University of Nairobi in the Department of Surgery. Thank you for the invite to give this talk. The talk I shall be giving today shall be Epilepsy, a Clinical Review and Surgical Options. Before we move forward, when I was invited to give this talk, the first thing I thought was that it's almost impossible. It's way too large. A simple procedure like hemispherectomy itself, you could discuss that for about 2 hours. Just think about the nuances, the indications, and what to do. So I had to think about this, and I thought about who I was talking to and where we work. And I figured that it has to be as simple, straight to the point, and show us what we need to do so that we can get better. So hopefully you'll find this useful. And if not, you can always let me know. I'll give you my contacts at the end. So what are we going to go through? We'll go through 4 main parts of this today. We'll have an introduction, which is the things that you most likely know, how we diagnose epilepsy, what we're supposed to do with it. Next, the treatment options, the surgical treatment options. And 4, the most important part for me would be the way forward. What do you do after listening to this so that it's not just an academic exercise? So the introduction, we're going to define what epilepsy is, the clinical features of seizures. Then we're going to discuss diagnostic tests which are necessary to diagnose epilepsy. Then the surgical treatment options. We need to identify diagnostic surgical treatment options, curative treatment options, and palliative treatment options. And the way forward is you need to have key takeaways and applications that we can use from this talk to move forward. So, introduction. This is most of the stuff that hopefully all of you already know, but we'll keep saying it because once you reinforce, you get better. Now, this is a very nice quote that I like. This is Scott Hamilton. He's a well-known American figure skater. He had secondary epilepsy due to a brain tumor. I must confess, I don't remember what the brain tumor was, but the quote says, the only disability in life is having a bad attitude. So any of you residents, if you keep on complaining, all you know is that you're giving yourself a disability. But here's the thing about epilepsy as we get back on track. So many people live with epilepsy and we don't know. I think being in a third world country, we tend to associate with a lot of stigma and disability, but there are very many people that you see every day that you don't realize are well-known advocates of epilepsy. Let me give you a couple of examples. One is Prince. Not many people realize that Prince is a well-known epileptic that was well-controlled till his untimely death. Next, for the younger generation, this is Lil Wayne. Lil Wayne is a well-known epileptic that's been under control since birth. Others would be people like Danny Glover. This would be for the older generation. You might know him from movies like Lethal Weapon. And slightly younger, people might not realize that in the movie Matrix, Neo was fighting an epileptic who was Mr. Anderson. So this is just to show you that you can have a good, fulfilling life with epilepsy. That doesn't mean that your life has to be tainted in any way whatsoever. Now, let's define what epilepsy is. But you're going to start thinking, who's going to define epilepsy for me? You might note, when I was an undergraduate, we used to have so many different definitions of epilepsy, and no one could get it right. It's not something that we were taught in a very straightforward manner. And there's a reason for that. There's too much literature out there, and different bodies had different things. But now, we have the International League Against Epilepsy. This is the preeminent body that collates lots of epilepsy research, and they meet all the time and they give us different recommendations. So far, as of 2017 was the last Congress that they had, and these are the definitions that we have for epilepsy. So it's a seizure, it's at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. The next one is 1 unprovoked reflex seizure and a probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over the next 10 years. That's a really long time. And 3, let's see if it's working. 3 is diagnosis of an epilepsy syndrome. But that seems silly. What do you mean epilepsy syndrome? There are many things like spasmus mutans, which all of you are very aware of. That in itself gives you a diagnosis of epilepsy. But if you keep reading there, we keep talking about epilepsy and not seizures. What's the difference between epilepsy and seizures? So we'll do this in reverse. Instead of me telling you what a seizure is and showing you what the problem is with people's definition of seizures, let's classify it first. So still, according to the International League Against Epilepsy, we have 2 classifications of seizures. So we have one, which is the basic version, which is not for people who deal with the brain primarily. And then we have the other one, which is for you and me, people who deal with the brain every day. So let's start with this. If you give me a second, I can put my pointer. I hope you can see my pointer. Yes, you can see my pointer now. So we have three things: focal onset, generalized onset, and unknown onset. So what differentiates focal and generalized onset? Very simple: whether or not the patient is aware of what is happening or not. If they're aware, it's focal onset. They could have partial or impaired awareness. They know that something is happening. Generalized onset, they rarely know what's happening. You tend to get third-party history. Unknown onset, these are the ones that we tend to see most of the time. We don't know where they came from. We don't know how things happened. The story doesn't seem to be the same, but you highly suspect that they have seizures. And these could be motor or non-motor. And then there could be the unclassified ones. These are the complex ones that we're not sure, but we have to watch to see what happens. So with all of those, they can be, for focal onset, they can become focal to bilateral tonic-clonic. Now, aside from that, let's put some more meat on these bones. So for everybody else here, we still have the same three: focal onset, generalized onset, unknown onset. And let's start to populate these with a few more. So patient can be aware or impaired awareness. Motor onset seems like things like automatisms. Remember, automatisms can be very complex movements. The older you get, the more complex things you learn. So we'll have things like bipedal automatism, so people who are sleepwalking. You've had these things of people going to drive, that can happen. Atonic seizures where everything goes flat. Clonic seizures where everything just starts to move all the time. Epileptic spasms, which everybody's aware of. Hyperkinetic spasms, which we all know. Myoclonic jerks, tonic jerks. Then we have non-motor onset. We have things like autonomic seizures, things like erections, sweating, palpitations, behavioral arrest. They just stop being who they are. They change something else. Cognitive, they start thinking differently. Emotional lability. We had many of these. I believe at UoN-KNH National also, we had this girl who completely changed her ways, to say it politely. And it's only her mother who kept going with her. And we found out that she did have, in fact, a large frontal meningioma. We also had another one, a gentleman who had severe depression, not refractory to, severe depression refractory to antidepressive medications, and developed seizures, and he had a large frontal meningioma. After that, he didn't need any of those medications, and sensory, which we've spoken about. Then we have generalized onset, and these are the ones that, this is what people normally think is a seizure. So we have tonic, clonic, all of these, I wouldn't waste time saying them. Typical, atypical, myoclonic, eyelid myoclonia. Then we have unknown, which could be tonic, clonic by the time you see it, epileptic spasms, or just a change in behavior, but you don't know how it started and you don't know what's going on. This might take long to see. And all of those give us a large picture of types of seizures. But wait, we've still not defined what a seizure is, and we have to define what a seizure is. So I want you to watch a small video and you tell me what you think the problem is.
Epilepsy is the most common serious neurological condition affecting millions of people of all ages and races. It is characterized by the presence of recurrent seizures, also referred to as convulsions or fits, due to increased activity of brain cells. The normal brain function is disturbed in epilepsy, resulting in convulsions, involuntary muscle spasms, strange sensations, abnormal behavior, and eventually loss of consciousness. The type of symptoms an individual experiences during an episode of seizure depends on where the seizure begins in the brain and how it spreads.
Good. So that's, I would say that's about 70% correct. But for you as a medical professional who will deal with seizures, there's one big problem that needs to be said. That's not the standard definition of epilepsy. The standard definition of epilepsy is, it's not increased firing. Everybody says increased firing, but it's not. It is disordered cortical firing in an epileptogenic focus. It's disordered or disorganized because it can be increased, decreased, staccato. So it can, there are very many different patterns. And the second most important thing is an epileptogenic focus. That's more important because of us as surgeons, where we come in. The epileptogenic focus can be physiologic, it can be anatomic, it can be structural, it can be due to injury, it can be pathologic. So all of that is what we aim to define, and that's what you should keep in the back of your head. When you hear somebody has a seizure, you have to think why. You need to find the focus, and more so if the person has epilepsy. Now, that's all well and good telling you all of the stories about what's happening and how to define it. But charity begins at home. So what's happening locally? So for this discussion, we're in Kenya and I'll stick to Kenya. So I did a long literature search and I found this paper, and it's Epilepsy Diagnosis and Management of Children in Kenya, a review of current literature. So they did most of the hard work for me. So I think they identified about 908 papers to deal with epilepsy from all different cadres, but only about 35 met their strict criteria. From those 35, we got some very, I would say, harsh statistics. The first thing that shocked me is the lifetime risk of children to develop epilepsy in this country in the year of our Lord, 2019, the time this paper came out, was 20 to 41 per 1,000. That is ridiculous. 20 to 41 per 1,000 chance of developing epilepsy. I mean, children will develop epilepsy in their lifetime in the country. I thought that was frankly ridiculous. It goes up to about 200 per 100,000. So what we're saying is that this is unreasonably high. And the other issue that they have is the definition between seizure and epilepsy was lacking between medical professionals and all cadres. So it was spread up and down. So what we know is that these people are there. Whether or not they're seeking help is something that we're not aware of. The next thing that we went to do was, so when I looked and I found if it's that much, is there anybody who's looking to see how many of them are dying? And then I found this paper, which came out last year from Kilifi. Now, so the previous paper was done by people at the Aga Khan University Hospital. And now this done at Kilifi, what they did is they checked all the patients that came to them. And for those who are unaware, Kilifi is a coastal town. I wouldn't call it a metropolitan town, but it's a relatively a big coastal city. Now, at this hospital, they had about 4,000 unique visitors with epilepsy, and they divide them into two groups, people with epilepsy and people with non-epileptic seizures, and they checked the mortality rate. I think the mortality rate was about 6.3 per 100 for those with epilepsy, the PWEs, versus those without epilepsy or non-epileptic fits, which is about 2%. Those are still quite high. So if you're interested, you can read these papers. You can see the DOIs here and go and get more information regarding this. You can see the causes of death, etc. But I think the main issues are the same. It's identifying the type of epilepsy, the follow-up of epilepsy, understanding anti-epileptic drugs. What's good is people can seem to know how to deal with status epilepticus and epileptic emergencies initially, but the burden of care starts to get a lot worse the more you deal with people with epilepsy, and the understanding tends to be a bit less. Now let's go. This is where the fun begins, as you can see there. We're going to talk about diagnosis of epilepsy. So let's create a picture. This will be the stereotypical resident. All of you were there. Hopefully some of you are still there. And this is you at about 3 o'clock. You've been called to review someone and you've been told what I think is the most useless information. You've been told, hey, hello, mtoto ameanguka. That means has fallen for those who don't speak Kiswahili. Now, and that's all you keep being told all the time. Then, depending on the resident, if it's 3 o'clock, you have other things to do. Your consultant has given you things to go and write. You have subjects to read. You might get very stressed. And at some point, the history gets lost. Then you just say, child with seizures. Next thing, somebody will write child with epilepsy. Then they leave it from there, and everybody starts managing the patient. Does this seem familiar? If it does, herein lies the problem. You have to get a pretty good history. So whenever you see anybody and you've been told seizures, you need to just go back to the history. The first thing you have to do is differentiate it from any movement disorder. There are a myriad of movement disorders. Your Merit's Neurology has chapters and chapters on movement disorders, which I advise you to go through. But with this, as we said, seizures have 3 parts. We have the pre-ictal or the aura, the ictus, and the post-ictal. So the pre-ictal normally tells you where the focus is and where it's starting. The ictus tells you how it's spreading. The post-ictal tells you how bad it's spread and the magnitude of the seizure. So when you go, what are a couple of things you should look for in the history? So here, you should look for seizure frequency. You should look for sleep activation. Look for seizure onset, progression. Look about if it's initially motionless. Look for automatisms. Things like bipedal automatism, which I told you about before, complex postures, motor signs, somatosensory symptoms, speech, seizure duration, secondary generalization, post-ictal confusion, post-ictal dysphagia. All of these would tell you something as simple as whether it's the frontal lobe or the temporal lobe, which are the two most common. But we're neurosurgeons, so you'll mostly be concerned with the temporal lobe. And with that, we'll look about this. So you think about ictal speech arrest, ictal speech preservation, ictal dysphasia, ictal emeticus, urinary edge, and things like goosebumps. All of these will tell you if it's the dominant or non-dominant hemisphere, and that tells you how you need to manage the patient. And think of it, and remember this, it's because you don't just want to send them home with anti-seizure medication and hope that they get better. So you need to spend time with them, especially once it starts to become refractory. You need to go back to your history. So we go back to this place. So we go back, you see this, no matter how tired you are, if you hear somebody has had seizures, make it casual, make it as normal as possible. Just like having a long craniotomy. The craniotomy doesn't care what you feel about it, you still have to do it. And I'll keep emphasizing history taking. So that's the first thing to diagnosing seizures. And from there, we go to something that, this is a picture from a German company. It was all over the internet. I believe it was about 2014 or so. I stand to be corrected. This picture was all over. They donated 3 of these machines to Kenya, as they said. One of them was donated to KMTC, which is right across from Kenyatta National Hospital. How many of you know what this is, or how many of you have seen this? You can just type in the site. This is a scalp EEG. Now, if you're going to take anything away from this, take this. EEGs are the gold standard for diagnosing epilepsy, not diagnosing a seizure. Diagnosing a seizure is your history. Diagnosing epilepsy is the EEG. Now, what types of EEGs are there? There are 2, wait, before we go to what types of EEGs, I forgot about this. This is still from another paper, and I need to show you what the issue is. This is 2019. Now, if by the time they're donating EEGs to KMTC, how many of you work in the districts? How many of you have seen an EEG? And if we're having a lifetime risk of 20 to 40 per 1,000 and about 200 per 100,000, that means that this is widely prevalent. How many of you have seen an EEG in your hospital? And therein lies the problem. I'll read this verbatim. Health facilities in many areas lack specialized hospital equipment crucial for investigation of epilepsy, such as MRIs and EEG equipment. Public healthcare facilities for children with epilepsy in Kenya are particularly limited, and national investment in such infrastructure and efforts to integrate epilepsy care into existing primary healthcare systems is inadequate. It's unfortunate when we were doing PHC, epilepsy was not added because it's a silent thing that no one is seeing. But as you saw from the news report at the beginning of this, people are starting to take note because the public is getting more and more educated. Okay, let's go now to types of EEGs. So there are 2 main general types of EEGs. One is better than the other. So what we've seen are these scalp EEGs where you put numerous electrodes and you measure electric current across the scalp towards all of the different areas, and you'll get multi-channel EEG recordings. EEGs are the easiest thing to read because you have something that's normal, then you'll have a part which is abnormal or not following. Then you just need to go and check and correlate as to which part it is. The one which is better would be these video EEGs. So we haven't reached this yet. I don't know many facilities that can do this. I do know some patients that are able to buy this or do this themselves. So what happens is you have the patient, you put the scalp EEG monitoring equipment. This is done in the hospital setup, and they have continuous video recording. So the continuous video recording takes us back now to that history so that we can see and analyze what type of seizure it is. When you can tell it's happening in the hospital setup, different things can happen. People can come and ask questions, especially if it's a partial seizure, etc. So you can see naturally, this is better than this. Remember what I was talking about EEGs? You can see here and here, there are problems. All you have to just go back and see where was the placement of the electrodes. Do you need to memorize it as a neurosurgeon? No, you have more important things to memorize. Okay, now this is a picture of an actual patient, one of my patients. This is a young boy. If I remember correctly, this is a young boy about 13, 14, couldn't focus in school, couldn't concentrate, grades went down, was known to have seizures for a long time, but they just kept getting generally worse. He started having things like emotional arrest, forgetfulness. Then they started spreading to generalized tonic-clonic behavior. And by the time he came to see me, I think it was about 4 anti-seizure drugs. Now, before he came to see me, he had multiple scans. All of them were put as normal. At no point did somebody ask for a seizure protocol. He went to a very good neurologist who asked for a seizure protocol, and then we saw this here. Then he was referred to me. And as we look carefully, I labeled it for you. You can look and you can compare both sides. So at the T1, what you'll notice is that one side seems to be slightly smaller. You can see this right here if you compare the architecture. The next thing on the T2, you see that this place starts to light up. Now I'll give you 2 seconds if any of you can tell me what this is. This is the commonest reason that neurosurgeons would do surgery for patients with epilepsy. I'll give you 5, 4, 3, 2, 1. It is mesial temporal sclerosis. Yes. Yes, I know some of you already knew this, so that's good. Now, before we go that, allow me to crack a really bad joke. I recently just learned about the 7 princes who became the first oligarchs of Russia. And I just realized we have 7 imaging modalities that we're supposed to do in epilepsy. So these will be the 7 princes of epilepsy surgery. So we have positron emission tomography. And with that, all you look for something that's hypometabolic interictally when there's a seizure. Then you have spectroscopy. Then you look for hypoperfusion interictally. The only other thing with SPECT is you can overlay SPECT, which is a CT, on top of an MRI when it's done at the same time. I'll show you some images. And you have magnetic EEGs, encephalography. These ones you'll see interictal epileptiform discharges. It also allows you to do functional mapping. It also gives you some positives when you don't see them on traditional EEGs. So there's utility. Then we have the WADA test. WADA test is just for localization of functions within the brain. What you do is you pretty much just knock out some parts of the brain and see if the patient is still able to do things, and we'll go through that. WADA test is also really good because it helps predict post-operative decline. So with a bad WADA test, this is not a good candidate for surgery. Unfortunately, there's nobody that does WADA locally at present, even though now we have many endoscopy suites, and we'll see that. fMRIs are available here, just depending on the protocol. You just have to request it, and you can do sensory and language function. And then at the same time, this goes hand in hand. You need to do neurophysiologic testing when you're doing any of these. Okay. Now, what we'll do is we have these 7 princes of epilepsy surgery. Now, I'm sure all of you are wondering, but doc, do I send them for all of these things in the clinic? And am I taking all of their money? No, it's supposed to be integrated. And now what I'll do is I'll show you a center that's integrated everything together, and it will walk you through with one patient. All right. Now, before we do that, let's do PET. So this is positron emission tomography. And with that, you can see the brain is lighting up. It's all the way lighting up. But as I said, what happens is it becomes less, let's go back here, you can have a look. It becomes hypometabolic interictally. Sorry for dancing, as they call it. As you can see here, this part is hypometabolic. So just like that boy right there, this part, which seems to be the middle temporal lobe, mesial temporal sclerosis, seems to be hypometabolic. It's blue during the seizure. Now, this is to show you, when I started, there were no PET scans within the country. This is 2018. This is after I graduated. Aga Khan University Hospital launches the first PET CT. So if you really want to find out, you can send your patients there to find out. But wait, this is a private facility, and most of us seem to work in government facilities. Yes. This is the cyclotron. That's the machine that does PET scans at KU Teaching Hospital, Kenyatta University Teaching and Referral Hospital. You can see it's a state-of-the-art cyclotron, even better than the one at the Aga Khan. So we do have a public option and a private option for PET CTs. So start doing them so you can start learning how to, when they're useful. All right. This is an overlay of SPECT. So if any of you are looking at this, you're wondering what image this is. So this is a SPECT, which has been overlaid on top of an MRI. And this one becomes hypermetabolic interictally. So as you can see there, the same thing, the medial temporal lobe, which is smaller, is really lighting up. But you can see this one is spreading to also go to the lateral temporal lobe. So this patient would have both medial and lateral temporal lobe signs. Right, this is the one I've never seen. It looks like a very nice machine, but the nicer the machine looks, the more expensive it is. So this is an MEG, And if you can look at it, you see that this one isn't localizing at any point. And see, what it does, it gives you like an MRI, and down here, it also gives you our beautiful, nice recordings. So this one seems to be a diffuse. This is just a picture I got off the internet. It's not of the same patient. Right. Now, this is what I was telling you about how we have to integrate all of the investigations together. So this was done in New York. This is a retired fire lieutenant who suffered from, I hate the way they say brain bleeds, who had a hemorrhagic stroke and cerebral edema in 2016. And then they were suspicious that he had other underlying causes. What they mean is AVM. Remember, AVMs are one of the things that can cause, sorry, I'm getting tired, that can cause seizures or epilepsy. So they decided to do water test. I want you to pay keen attention to how they integrate all the tests together.
We in the CAT scanner and rest I don't have a lot of memory of.
Well, he came in specifically for a procedure to determine on what side of the brain his memory was localized to hold the WADA procedure.
So what is the purpose of WADA test is, as we know, the left brain leads the right side of the body from motor-wise, movement-wise. The right brain leads the left side of the body. But in regard to language and memory, it is not very clear-cut cookie.
I oversaw the EEG and I did the clinical exam. Basically, the EEG is to look at his baseline brain electrical activity. We characterize it prior to the injections of the medication.
Catheter goes up to your groin, and they administer a short-acting anesthetic.
FDG.
Parts of your brain.
During that time when the injections are made, we're using the EEG to determine whether the brain has been completely suppressed or put to sleep. For his case, the neuropsychological component of the testing is probably the most important part because it's testing his visual memory, his verbal memory, it's trying to figure out what side of the brain the memory is localizing to.
If we go to the right quadrant, we ask the patient to hold the left arm up. So once we see that the arm is falling down and the EEG showing the suppression of the brain activities, we know that this brain is numbed. And once the shank comes back and the EEG comes back, we know that that's the time that his brain is back to normal. And again, we will reevaluate the patient.
I think this is important in his case specifically, is to determine if he needs to go for a biopsy, what side of the brain would be more.
Okay. So now I want you to pay attention and see what happened. You notice it's not the neurosurgeon doing everything by itself. I know you couldn't tell, but there's a neurologist there. There's a neurosurgeon there. There's an endovascular surgeon there. But at least this time, the neurosurgeon was also the endovascular surgeon. There's also the neurophysiologist who was also there, and the radiologist. So that's already a multidisciplinary team of 4 people just to manage just one patient. And that's where we should be moving. Okay, and now, like, so some of you, I can hear behind your screens already saying, okay, that's well and good, but doc, why do I need all of these tests? I can just give him this furniture and go home. And then if I get a tumor, I can operate, but you're missing some of the points. There's one reason why we do all of these tests, and you need to escalate as appropriate. EEG would be bare minimum. And the reason we do all of these tests is simple general principle that you need to remember for anytime anybody asks you about operations for epilepsy, it's this. You need to ask them, where's our epileptogenic focus? That's the main point of this. So I'll read verbatim. The goal of pre-surgical evaluation is to determine if the patient has a single epileptogenic focus that is not in eloquent cortex and can therefore be resected without causing an unacceptable neurologic deficit. That's the main reason. This last one there was just to reemphasize that we miss a lot of these cases. Is the most common location of seizure onset in adults and patients is the temporal lobe, especially the medial temporal lobe, the hippocampus. And that's also the location that's most amenable to surgical cure. So you're missing them. If you've not done one before you've graduated, you're not looking at them. Look at your seizure patients properly. Now, let's go to the surgical procedures, and this gets really exciting. I need one addendum. To do this justice, 2 addendums. To do this justice, we would need to literally pick one procedure and discuss it at depth. But more importantly is for you to realize why you're doing it. The second addendum is, if you actually think about the procedures, they're very easy to do, but you have to have very concrete anatomical understanding. Sorry. Once you have good anatomic understanding, doing most of these procedures are going to be very, very simple. So once you have good safe hands and good technique, you can do any of these procedures. And what are these procedures? So they're put into 3 main procedure types. We've talked it's all about the surgical focus. That's the whole reason we even get involved. So one is you can do something to help identify the seizure focus with your knife. You can do what most of you are thinking to remove the seizure focus. And then the other thing you can do is you can do something where the seizure focus is way too large for you to do anything, or it's right next to eloquent cortex. So what are these things that you do? We do diagnostic surgery. I find it such a funny thing to say diagnostic surgery. The other thing we do is curative surgery, which is what all of us want to do all the time. And the last one is we do neurostimulative and palliative procedures. You can already see working within the local industry, all we do is focus on curative procedures. We're missing diagnostic procedures and neurostimulative procedures. Once in a while, I might see some diagnostic procedures and neurostimulative and palliative procedures for epilepsy, but they're not the norm. Okay, so let's go to diagnostic procedures. First time I heard about this, I thought it was so complex, and only to laugh at myself and realize it's actually not complex. Though you, as they say at the University of Nairobi, you have to have meticulous attention to detail. So what you do is you get a brain grid or subdural electrodes. I'll show you just a flat sheet, which is labeled, not unlike our EEG labels. And this is because the current to go from the brain all through all of those layers to the skull, sometimes you can't identify or localize or pinpoint. So sometimes you'll have a general area, which could be, it's coming from this hemisphere, and you want to find out where from this hemisphere would it be safe to resect. So then you go and do this. So what you go and do is you just do a formal craniotomy. Once you do a formal craniotomy and you remove the bone, you put this little brain grid and you just connect it to the electrodes. I think I have a better picture. Yes, there you go. And this is how it looks from the top. And just like before, everything is labeled. So you have to have meticulous attention to detail, know where everything is. You have to be very aware of where your anatomy is. And with this, you will map the brain and know where the seizure is coming from. So let's say you'll say seizure is coming from, it starts at 13, going to 5. You'll know you'll resect this area right here. But how would you know where it's going? You're right. After you do the formal craniotomy, you put everything back, and then you send the patient to an epilepsy center or neuromonitoring center. And there they'll do all the things that we did. The video EEGs, the continuous monitoring, and you identify, yes, this is the actual point where it happens. You don't send them home. So you see, we can't do this procedure unless we have an epilepsy center. So this is just showing you how it looks. So this is a patient who did a large hemicraniotomy. You can see the frontal lobe, the parietal lobe, the Rolandic fissure, the temporal lobe, the occipital lobe, done nicely and beautifully, but you can see they bled a lot. I'm just joking. Then as you can see, they put multiple grids here. This is why you have to have meticulous attention to detail. It's not something that you're hurrying to do. The fun thing is it's not an emergency. You're planning when to do this. And you can see they don't think this one is coming from the temporal lobe at all. So they've left the temporal lobe completely because they got a good history. They probably have an EEG as well, so they know where to focus on. When you put everything back, this is how it looks. When you do your CT scan, you can see on the bone window. And what you have in some facilities, you can map like this, 3D mapping, so that you can see where everything is coming from. And then from there, you'll know where you will be planning to resect. Okay. But I'm sure some of you are thinking, but doc, not everything is going to be superficial. Right? If it was, life would be very easy. Sometimes things are going to be very deep. And you know, we don't like going for deep things blindly. So with that, we use depth electrodes and we do something called SEEG, stereotactic electroencephalogram. This is, I'll show you the picture, then I'll show you how you do it. So with this, we get those really deep probes and you put them in specifically targeted areas that you suspect things are coming from. So these are not for superficial things. But I'm sure if we stop, let's stop and think very practically as neurosurgeons. Some of you are thinking the same thing. Doctor, I could get lost. It could be super deep. My trajectory might change. But I'm not too comfortable putting this deep thing. I might go and knock off something. And you're correct. So how do you think they're done? We don't do them blindly. So what you need to do is you need to use some form of stereotaxy or neuronavigation. Most of the time people use framed stereotaxy. And for framed stereotaxy, you have the frame which has been measured. And with that, you know that there's no risk of movement. The only problem with framed stereotaxy is the measurements have to be very correct. And you'll get something that looks like this. So you would still go to theater and you'd put 1, 2, 3, 4. Fortunately, I didn't get a picture of the frame. This was frameless stereotaxy that was used. And I'll show you some pictures of frameless stereotaxy. The other thing that more advanced centers use is, they use this. If any of you have seen this before, some of you have worked with this. This is a robotic arm. So I don't know which one this looks like. It's called a ROSA. This is a ROSA robotic arm. So what happens is the robot has been programmed with things as the trajectory, and all the surgeon does is goes to where the robot is holding and pushes it in, and you label everything. I hope you see the main thing about this is labeling and following up. After this, you send them to the epilepsy center, which should be in the hospital. But things are not that bleak. We already have frameless stereotaxy, at least within 2 hospitals in Nairobi. We have frameless stereotaxy, otherwise known as cranial neuronavigation. As you can see here, with an MRI overlaid on top, and with this pen here, you do registration. So the pen has gone through all of these parts. So with this, you can identify some of the deep foci, but you have to be meticulous. The patient cannot move. If the patient moves, you can see that you can get into the wrong trajectory. So it's not the type of thing that you allow residents to come and touch the head and move the head. This is a very nice, delicate procedure. But the good news is it's possible, and we're moving there. Okay, I've already talked about this. So with diagnostic surgery, it's just the first part, it's not the end. Epilepsy unit, preferably in the same institution. Then from there, you make a decision as to do curative or palliative surgery, or even no surgery at all. So let's go to the non-diagnostic procedures. I know this is where all of the surgeons have been waiting. I can see your hands have been shaking with bated breath, shaking kind of like that. So let's go through them. Let's start with the resections. These are super easy to do, as long as you know the anatomy. And these are the formal ones that you do. Anterior temporal lobectomy. So many of you have done that in trauma theater. Hopefully a formal one. Lesionectomy, all of you who have resected a tumor have done that. Neocortical resection, all of you have done that. Hemispherectomy, you have not done that, and we'll talk more about hemispherectomy later. Then you have the other ones, which is what most of you thought would be the surgeries we talk about. Things like corpus callosotomy, multiple subpial transections. I call that just the little sauce that you add on top. And then the ones where we're going, I would like to do these personally because they are very easy to do and straightforward. Would be, okay, maybe not deep brain stimulation. So deep brain stimulation, vagus nerve stimulation, responsive neurostimulation looks very high tech. It looks very fun to do. I don't know why we don't do it here. This is also long, low hanging fruit, though it seems like the implants would be expensive. So let's talk about anterior temporal lobe resection. So this is a section to include the amygdala and hippocampus because they're believed to spread and intensify seizures. The indications are 3 main indications, not trauma. The 3 main indications are medial temporal lobe sclerosis, the commonest reason we're called in to operate for seizures, stroke, and then recurrent tumors. Now, the outcomes with that normally include people tend to be seizure-free, depending on the series, 34 to 74%. The most frequent complication you can remember, which is why for the 3rd years, we always ask you to talk about the visual fields, will be a visual defect occurring from the temporal lobe resection, if you go through Meyer's loop. And this is how it looks. So if you look carefully here, this patient, this is the tip of the temporal lobe, and we're coming around here. The standard one is about 7 centimeters from the tip of the temporal lobe, and then you go down. It's nothing too complex. All you do is you just coagulate and suck, coagulate and suck. If it's in the dominant hemisphere, it's about 5 centimeters. And you have to decide if you're going to spare the superior temporal gyrus or not in the non-dominant hemisphere. There you go, very simple, straightforward procedure. There's no point me going through the steps. This is another one. This is the one that all of you have done. If you've done any intraaxial temporal lobe lesion, this is what people equate to epilepsy surgery. This is also another patient this is a patient from Kenyatta. The previous one was a private patient. This is just craniotomy for any lesion. Let's go through this. As you can see. So this is exactly what you think it is. This is a patient at the Kenyatta Hospital who had a large metastatic lesion with neurovascularization that you can see there. So the main indications are medial temporal lobe sclerosis, stroke, AVMs, and tumors. We always do this for tumors. You get seizure-free in 2 out of 3 patients from most series. That's about 66%. Now, in the best centers, we do brain mapping, which is pretty much what we've just said. All of the investigations that we do for epilepsy are to map the brain so that you know the extent of the resection. If not, we just stay 1 centimeter around the lesion. Next, we have this hemispherectomy. This is rarely done. This falls into the domain mostly of pediatric neurosurgery. So it's either partial or complete resection of the hemisphere, but it's not removing the hemisphere itself. We hardly do that anymore. We've moved more to functional hemispherectomy, and functional hemispherectomy means disconnection of parts of the brain. So you have to do formal disconnection of all of the parts of the brain. The indications are here. We have congenital hemiplegic strokes, hemispheric syndrome such as Sturge-Weber. Both of these we do see at our facility, but we don't seem to manage. Hemimegalencephaly, which you rarely see, and then extensive unilateral cortical dysplasia with severe hemiparesis. The indication for this, it doesn't seem to yield that much benefit, but with these other 3, they tend to have marked resolution. What are the outcomes? So it stops progressive neurologic decline, especially seen in infantile epilepsy syndromes. About 75% of them end up being seizure-free, which is amazing. But if you can get things like hydrocephalus, superficial cerebral hemosiderosis, post-op cerebral edema, postoperative infarcts, especially if you ligate the wrong vessels, and of course sinus thrombosis. So these are significant risks. So it's not something that you should try without knowing. This is a video that I got off the internet showing a functional hemispherectomy that you can see there. If you're keen, you can see that this is the insula that they are starting to disconnect. You can see the way he's very targeted in this disconnection of the insula before he removes everything. This is the insula. So this is the last part of the temporal that's going to go. Remember, the amygdala and hippocampus are what are expected to spread seizure, or what are suspected to spread seizure activity. So let's just let it go through until you can see them resected. There you go. And there it is. It's gone right there. You can see all that has gone. Temporal lobe, insula has gone. You can see the floor right there. Right. This is the other one I just called the salt, the thing that you can add into other procedures if you want to be fancy. So this one, you just transect horizontal connections between cortical neurons, responsible for the epileptic. This is a picture of somebody doing laser interstitial thermal therapy for what is a glioblastoma that was causing seizures. You can see this one is very deep-seated. I wouldn't go for surgery for this, send them for laser interstitial thermal therapy. The next thing you have is stereotactic radiosurgery. We're not here yet, but we are getting there. The more utilities we know for stereotactic radiosurgery, now we've added seizures, the more we can request for it. And this is a big one because if it's, I'll repeat that number, if it's 40 per 1,000 in a population of 55 million, you have a lot of work out there. That's lifetime risk. This is the one that I would like to do. This is deep brain stimulation. So with deep brain stimulation, you stimulate direct deep centers using multiple devices and electrodes. It's a long procedure because it takes lots of brain mapping. But think of it not like our depth electrodes, but you connect it to something which will keep giving you electrical discharges. It may also have a sensor to say when there's disordered firing. There are many utilities for deep brain stimulation, and patients love it. They love it especially because they are in control of it. For things like Parkinson's, etc., they press and everything goes back to normal. This is another one, vagus nerve stimulation, almost the same thing with a few indications. This is not something that we do, but this is a procedure that you can go and learn. Well, not unlike deep brain stimulation, but this one, the generator would be put under the chest. This is funny because I was speaking to the junior residents. This is another reason why you have to pay attention to your anatomy in first year and second year. You can't start reading your anatomy of the chest when you're a consultant. And this is what I said looks very fancy. So you have responsive neurostimulation. This is almost like deep brain stimulation, but now this one has the sensor itself. So it picks up the charges and it either ablates them or stops them. So it has a sensor unit and it has an effector unit. And so it's like, this is what Elon Musk was trying to do when they're saying, put things under our brain. So people already do this here. This is why I said this is fun to do. But you already see you need a craniotome, you need lots of screws, you can see you need lots of equipment here, and the follow-up for this patient needs to be significant. If you pay attention, you also see this is a stereotactic frame. So this is not being done blind. This would be a very long procedure, but it looks like it would be a fun, rewarding procedure. All right. And now the way forward. Where do we go from here? The future is calling. We can't stay in the same place that we were all the time. Somebody has to keep moving forward. So the first thing that you've noticed, the neurosurgeon is not alone. We're not the head of this. We're just part of this. So a multidisciplinary team is needed. So what you need to start doing, even if you start working by yourself and you go to your different hospitals, you need to start identifying individuals with interests so that you can start having discussions to keep moving it forward. So the neurosurgeon will just be there and offer options. So you need to have, we've not yet reached epileptogenists here. We still have a few neurologists, even though we have neurology training programs now and the number is increasing. So we need to start working with neurologists, neurophysiologists, psychiatrists, and neurophysiologists. No, neurorehabilitative physiotherapists. Ah, there we go. That's the one I was looking for. And apart from that, we need to do this, which is called organization and integration of care services. So this is the problem. We need to have feedback between the community and the healthcare system, which allows the patient and the family to get education and to seek care. Because imagine being told all of this and you're not a medical professional. You'll think everything is extra or somebody's trying to get things away from you. And imagine the way it is right now. You have to go to multiple different facilities for what you call basic things. Imagine sending somebody all the way to Canada National Hospital to do an EEG. It makes no sense. Once they get the EEG, next you have to send them to look for a neurosurgeon. These are all the problems that we have, and this is why we tend to lose patients. For all the residents who don't have any questions, this will be a good question locally to see what happens to any of our patients, to even find out how many patients have surgically amenable epilepsy at the epilepsy clinic, which is run by the internal medicine department. That's one good one. Two is find at which point they would get lost with care or find out what difficulties they face in accessing epilepsy care. Is it cost of drugs? Is it availability of drugs? Availability of personnel? Is it that they get conflicting information from medical officers, neurologists, neurosurgeons? That's a very nice question. And that would go very far. Then when would the neurosurgeon be involved? So I was discussing this with one of my friends, Dr. Beverly Cheserem, and I saw she had this, so I took this word for word from one of her slides with her permission, of course. When something's not broke, you don't need to fix it. So is there a focal lesion matched with EEG findings? Then you get involved. Is there a temporal lobe lesion? Then you get involved. Has medical compliance been proven and it's still not working? Then you get involved. Is the epilepsy refractory? We already said that, you get involved. What are the team's technical capabilities? What can you do? If you're not comfortable with a hemispherectomy, you have no business doing it. If you're not very aware of all of the connections between both hemispheres, you have no business doing it because it can be detrimental to a child's life. Is there access to video telemetry, which is what we saw, the video EEGs, or modern adjuncts? Modern adjuncts now, I forget the name of it off the top of my head, but there's an app now that you can download that gives you video telemetry. So with a phone, What you do is you can record, you place it somewhere or connect to a camera. And what it does, it can connect to any scalp monitoring device or electrode, and you get video telemetry or video EEG, and that you can do from home. Then timing of surgery, you need to think the burden of wellness. This is simple. Just because you can do something doesn't mean that you have to do something. So you have to think about how useful is it to the patient? What are you offering? Because are you helping the patient get better, or are you just doing something for yourself? So you have to think about the timing of surgery. And the best thing about this is it's not your decision alone. It should be in a multidisciplinary team. Now, this is one thing that I think every neurosurgeon gets tired of saying. Surgery is not the end of the journey. Living in a LMIC, everybody thinks surgery is the end because everyone is scared. They raised money and they think when they're going for this, it's this. So it is not the end of the journey. Surgery is just something that we add in epilepsy management. Sometimes it's the end of the journey if we're blessed with doing something like a lesionectomy and 66% of them will get better, then we're okay. But most of the time, it's not the end of the journey. The other thing that tends to happen is that we tend not to wean off anti-epileptic drugs. So we're not able to assess. So this is just a simple slide of, the other thing I see is everybody uses the same 3 anti-epileptic drugs for some reason when there are all of these that are available. And we don't get histories whether or not they're generalized or focal seizures. So take a screenshot of this if you're unaware, and just remember what you look for and when to use it. The last part is with all of these holes, who is going to tell government? Who are the people working in this field? It's you and I. So we need professional advocacy. So it's going to be small scale activities we can do, which can spread the word in large scale. So the small scale things are, we need to drive for new facilities and investigations. We had 2 PETs, the PETs are there, use them. It's as simple as that. If you remember, NHF said they will no longer be paying for people to do PET scans outside the country. They don't need to, there are 2 of them here. Next, you need to increase your technical know-how. Read about it yourself, go for short courses, do things yourself. The last one, wherever you go, any patient with a seizure, you need to start multidisciplinary seizure clinics to meet unmet need. The patients are there, but they're getting lost in the system. And that's what the research has shown. Now, large-scale things which will outlive all of you will be number 1, definition of disability. Different countries have different definitions of seizures as a disability. Some of you may or may not be aware. One thing I found out from one of my patients, there's a scam where patients go to get disability cards by saying that they're epileptic, because there are multiple benefits from getting these disability cards. One of the funniest ones I heard is you can buy any motor vehicle without tax, as long as you have a disability card. So there's a whole scam which I was completely unaware of, but they go down to the lower level, taking advantage of the fact that they're fewer neurosurgeons. So you'll get clinical officers and people who don't know what epilepsy is writing all of these things. That has to be changed. So we need to define what disability is. Next, we don't have any regional return to work formula. So what do we say? When do we say somebody is okay to return to work? If a pilot has 1 seizure in Kenya, can they go back to work? That's something that as you keep getting older, you'll start being called in for your professional opinion. And it'll be hard for you to decide, but it's easier to decide with a big group like UoN-KNH if we sit and we have little mandates and little things that we write. Next, we need multi-sectorial buy-in. You've seen management of epilepsy is not just one person. The neurosurgeon is one thing. Next, you need to have equipment. You need to have stereotactic frames. You need to have available drugs. You need to have EEGs. All of these need different sectors to come in. But the sectors can't come in if they don't know that they need to do that. The next thing that's needed is if there are all of these seizures, everyone keeps reporting lots of seizures. 1, are they actually real seizures? How do we know? We need to have a seizure registry. So you need to start either hospital-based seizure registries and move all the way to to national seizure registries. Those are large-scale things that will completely change everything. If we find out that we tend to have a lot of focal seizures, then we can go approach different drug companies saying, hey, we need these drugs in our country to be subsidized because you will get money. All of that is driven by us, and that's what we have to do. Now, let's go back to the patient. What is success? Success is if a patient is seizure-free. That's really happened. Seizure control is at least 1.
This is the last slide.
2 every 3 months. Then you say that's well controlled seizures. Improvement in mood disorders. This is one part that's overlooked, and this is why I said psychiatrists are part of this. If even you as a neurosurgeon, if you had seizures, even 1 seizure,
I think I can stop here on this slide. This is the last slide of what success looks like. Can everybody hear me? So as I was saying, just to be seizure-free, fewer side effects, social reintegration, and to help with oncotherapy and immunotherapy. I think that's it. Thank you for your time.
Thanks once again, Dr. Magoha, for that quite an animated presentation, literally. I know it's quite a long topic and it's quite brought a lot of interest, but time may not allow. I think it's a topic that we might need just to follow, to make a follow-up. So again, like we said, we'll have questions at the end. There are a couple of issues maybe that we might just need to comment on, but let's give the next presenter time. The next presenter.
Thank you, Dr. Have you given me the floor?
Go ahead.
Okay. You can hear me?
Very well.
Okay. Can I ask Nelson to do my slides? Now, as he does that, may I thank the organizers very much to have agreed to take me in, late as it might have been. Two, mine is a very short kind of a round table discussion. I hope I'll be somewhere in between after such excellent speakers, research, and clinical information that we have gotten. Dr. Wabwire, Dr. where are you?
Sorry, it looks like I muted before I completed. Sorry once again. I think, Nelson, could you load the slide for us?
Pardon?
You're waiting for, yeah, there they come. Yeah, so just to introduce you, I think I was doing the introduction, but I realized I clicked on mute, so I didn't quite complete that. So our next presentation is titled Social Anthropological Drivers. This being presented by Ms. Mary Kinoti, who is a lecturer in the Department of Public Health and Global Health. Mary Kinoti teaches both undergraduate and MPH students and has been doing so for the last 26 years. He's supervised quite a number of MPH students so far, I think over 20. He has quite a lot of interest in implementation science and is a fellow currently in the fellowship between University of Nairobi and the University of Washington. I think this is the last presentation and we expect her to take about 15 or so minutes before we can get into the Q&A session. So Ms. Mary Kinoti, the floor is yours.
Okay, next. Next slide, please. Now, I came across this quotation from the former Secretary General of United Nations that cancer, diabetes, and other diseases are no longer the diseases of the wealthy. And that reminded me of a colleague who did obesity in children in Kibera. And about 26% of the children were obese. And they were not obese because they were wealthy, but they were obese because of the kind of food they were eating when they were at home and when they were in school. It was easy for them to get the chips and they carry to school, high energy and density foods. So today, they hamper the people and the economies of the poorest population, that is the diseases, even more than infectious diseases. I think this is where we are going, and it's really going to be a monumental task to sort out the issue of NCDs, especially in developing countries. And he says that this represents a public health emergency in slow motion. But even in slow motion, we'll get there. Next. Now, I looked at medical sociology, anthropology, definitions, and so on. And in an integrated way, they deal with the social determinants and distribution of disease, attitudes and behavior of individuals, which are very critical in management and especially in prevention. And this reminds me of the just ending epidemic, COVID-19. And we realized how important it is for people to have the right attitudes and the right mindset for what the science is telling us. Now, this medical sociology, anthropology, there's emphasis on all the aspects of healthcare, that is preventive, promotive, curative, and rehabilitative. Next. So I got this chart from one of the publications, and I decided to pick the living and the work environments among all the other predictors or determinants of health. Next. Work and living conditions as NCDs push risk factors. The concept is we have people in good health, but where they are working and where they're living, they're exposed to some risk factors, they become sick, they go for treatment, they get well, they go back either to work or something, then they get exposed again, and this becomes a vicious cycle of good health exposure, sickness, good health exposure, and sickness. Next. 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 Where's Nelson? Okay. I don't know whether this is this can be seen, but what I'm trying to do here is that one, from work environment, we always say that both living and working environment where you find human beings, even in Stone Age, they are not 100% safe. You are exposed to something that could be harmful to your health. And on the left-hand side, we have some risk factors among some healthcare facilities where some of these diseases were elevated above the community level, blood pressure, diabetes, and being overweight, obese, and so on. And we have already heard from the previous speakers, these diseases become now the predictors of cardiovascular diseases. So we have factors that cause these diseases, which themselves now become predictors of other diseases. Now, we have similar, and there's a lot of information, there's a lot of publication for work environment and its impact on people's health, and especially workers. Some of the oldest diseases that were discovered among workers, like silicosis and even cancer of the testes because of exposure to chimney soot among the chimney cleaners, sweepers, those who are sweeping the chimneys that early. So the exposure to that soot targeting the testis and then got the testis cancer. So work and where we work is very important for our health, and also it elevates the NCDs. Now, on the right-hand side, I have the living environment. And you find that we have similar predictors of poor health, heart diseases, lung cancer, and so on, because of the exposures that we come across. Now, this could be due to exposures to chemicals in our ambient or outdoor environment, especially in urban areas. A lot of information is available on the impact on pregnancy outcomes, whereby exposure of pregnant mothers to air pollution, the particulate matter, as well as the particulate matter, PM10 and PM2.2, sulfur dioxide, ozone, and all the others that Professor Neil discussed yesterday, cause a lot of havoc to pregnant women. So you find they're having preterm, or sometimes the term babies, the term births are low birth terms, low term weight births, sorry, low term weight births because of air pollution. Now, so there's a range of all the other respiratory diseases that have been found from localized populations which live proximal to incinerators, for example, or generally where there are industries like industrial area and so on and so forth. So these are areas that need a lot of lobbying and a lot of discussions, conversations to be held for prevention. Next. Now, I looked at the impact of NCDs, not necessarily anthropogenic, but I found out that most of them, they are talking about the cost of healthcare and the restricted ability to work, and also household struggle with increased financial risk. But very little, I have not found, maybe I continue searching. I was expecting to find out whether we have costs of managing NCDs at the health facility levels, because I know the doctors are involved in it. Probably in public hospitals, what you get paid is not equivalent to the amount of time, and this is increasing all the time. So we have more patients than ever before. And also the caregivers. I think this is where we underestimate the cost of some of these diseases. Once somebody has got incurable diseases, non-communicable diseases, they will require care for as long as they are alive. And what you find is that people get exhausted, including the doctors. In fact, long time ago, I came across a study that indicated that myocardial infarction was very common among doctors and the pilots. And this was because of being in charge of other people's lives. When you compare them with those who are in those two groups, you find that these ones suffer more because of the stress that they go through all the time. So some of these costs, because the caregivers and the doctors might also end up with the diseases, these non-communicable diseases. I believe they are not diseases of only people who are not doctors. I believe even the population as a whole, you'll find traces of non-communicable diseases among every sector. So these are costs that are not taken into consideration. So what is taken into consideration is what they pay, but these other costs are not there. And I got this from CDC, Global Health. Next. Managing NCDs now and in the future is like pushing a trolley up an escalator. You know, I thought about how I feel when I go to a supermarket and I fill my trolley and I have to push it through the escalator. At the moment, I don't, because I'm afraid of rolling back with the shopping. So, because sometimes it's a bit heavy, and when it comes to coming out, I think I have delayed reflex action. So I always ask the employees to push my trolley up the escalator. So you find that both the doctors and the caregivers are always walking a very tight rope when they are taking care of people with NCDs. Now, this brings me to lobby for advocacy. From all what we have had this week, I've looked at all the presentations. A few have touched other stakeholders in the management of NCDs. But I think since most of the NCDs, not all, but most, are preventable, like it happened with the smoking. Smoking, I think people who still smoke today are those who we call risk takers. Otherwise, right-thinking people don't smoke anymore. In developed countries, if you have found that you have lung cancer, but you are smoking, the insurance might not cover the bill. So I think with those kind of lobbying and those kind of decisions, directives and registrations, I think some of these diseases can be prevented. Next. Now, challenges in management of NCDs from socio-environmental context. And for me, this is a personal experience. We have been trying to do a study, to carry out a study in the city of Nairobi to investigate an association between pregnancy outcomes and air pollution, the outdoor one, the outdoor air pollution. And this was on the premise that in 2001, some researchers from engineering, spatial engineering, did zonation of air pollution in the city of Nairobi, the air quality. They zoned the areas. And they published a paper that has got 3 major regions: highly polluted, the Eastlands, and then near Kenyatta Hospital is medium, and then Langata is low pollution. That is 2001. And I kept on thinking that probably, since we know there's a lot of literature linking poor pregnancy outcomes with air pollution, why don't you try and find out in Nairobi how it is? We are also, the other part of that study is also to get, to investigate an association between respiratory symptoms and the same air pollution zones. So the first challenge that we come across is inadequate data, both qualitatively and quantitatively. For example, what I have here is data from one of the registries on mobility from June this year. This is just part of it. It's about 12,000 within that month, and about 12,500 patients. I've not cleaned the data yet. But what I'm saying is that if we want a data that we can analyze epidemiologically, that can give us some evidence of what is happening on the ground, we need to have targeted data collected by our health facilities. I know the Ministry of Health concentrates more, gets more of its information about the health of the Kenyans from the hospitals. But the data sometimes which is collected is inadequate. Now, if this is about the variables that they have for outpatients, you'll find that smoking is missing. And we know that smoking is a predictor of respiratory symptoms. Employment is also indirectly linked to health, either good health or poor health. And most of the time, people think that when you get employed, you get money, you can eat well, and you have less stress, so you are healthy.
Ms. Kinoti, would you try, and we're running short of time?
Okay. And then pathology. Okay. So we have the data, the inadequacy, the qualitative and quantitative. Next. Preventive medicine is number 2. Approaches rarely applied to reduce risk factors. Rarely applied. Number 3, registration on occupational safety and health. That is the working environment. And the environmental management exists with profuse regulations therein, but no convictions, no implementation. Next. Way forward, paradigm shifts, more collaboration, advocacy for implementation of mitigation measures like registration, advocacy for health aspects in all policies across sectors. This was proposed by WHO almost 20 years ago, that every sector should look at issues of health and then improvement of data collection in health facilities that is targeting research used for national databases. This is another place where we can get a wealth amount of data, but it's never available. More national surveys to be designed as we gear towards full industrialization. Next, I think the readings, next. Thank you. I'm finished.
Thanks once again, Ms. Kinoti. Sorry, we had to hurry you up, but it's an interesting presentation,
That's okay.
especially transitioning these to NCDs. I think these are very important aspects as far as NCDs are concerned. Now we've tried to answer some of the questions. We've tried to respond directly to some of the questions. I'll give, however, I'll give the presenters time just to pick what they feel are burning questions that needs to be responded to in the plenary. So Dr. Judith Kwasa, are you still with us?
I am.
Yes, so I'm sure you've gone through the questions and you've answered probably almost all, but probably just pick 2 or 3 that you feel that are important for the interest of all of us that can be responded to in the plenary.
Right. Let me, sorry, I'm trying to multitask. It's not working very well. Right, I think there was somebody who asked, I can't see it here, but there was somebody who asked about Kawe and whether it's, you know, what's happening now in the rural setting. So my reply was, as far as I'm concerned, Kawe is still very much alive and well. And I know there are several clinics within Nairobi that are really just Kawe, Kawe is the Kenya Association for the Welfare of Epilepsy, that are purely Kawe run. What I am unaware about, and this might have to do with their funding structure, is whether they're still able to hold these clinics countrywide or whether they are now holding it in selected urban areas. But it's still very alive and well. It's still a hugely impactful project that handles patients living with epilepsy who are unable to afford a lot of the basic medication. And so it has, from what I believe, very subsidized prices for the drugs and a lot of available drugs that can be given. And of course, within this, because I see a lot of patients who sometimes bounce between Kawe and coming to see private clinics as well. We must remember that the drugs offered at Kawe are obtained in a subsidized way, and so they might not be able to access all different types of drugs, which makes sense. So they will access the ones that would give you a more broad cover and the ones that are a little more affordable. So sometimes patients will come from the private sector and have been on different drugs simply because that was what is available, and then go to Kawe and get frustrated because they wonder why they're not getting the same drugs. But really it's a matter of public health approach as opposed to coming in from a pay out of pocket sort of thing. So I just wanted to reassure that person that Kawe is still very much alive and well. I don't see any participants who are advocates for Kawe, but I'm sure there are some. Another question, sorry, go ahead.
Sorry, I was choosing for another question that I think catches, I'm sure you are going to pick it. Because one of the frequent questions people would ask you when you are starting seizure medication is lifetime treatment. Am I going to stop this medication? Am I going to get addicted? You know, those sort of questions. I believe that covers quite a lot of people dealing with epilepsy. So it's something I think you could respond to.
All right, and I believe just like you, that's always a difficult question to answer because I think people expect the answer to be yes, no, but no. So the way I look at it is when you fit the criteria for being started on a drug for seizures, meaning you've had more than one seizure, provoked or unprovoked, and there's the likelihood that you will continue to have seizures. Our aim in utopia, you know, in a perfect world would be seizure freedom, which means no more seizures, but this has to be with the use of medication. In a large percentage, we're not able to get to 0 seizures, but we're certainly able to get to what we consider control. And I told you the definition of control is varied in that either we're decreasing your seizures by 50% or we're bringing it down to about once in a month for most people. Now, that said, there's a small percentage of patients who we are able to achieve seizure freedom, meaning they've had no seizures. And when this has happened with the use of medication for a period of 2 to 3 years, depending on which practitioner you're leaning towards, then they are able to slowly reduce the drug and see if we can continue to remain seizure free. In a small percentage, we're able to decrease the drugs to 0. And in these patients, we're able to wean them off medication. But I will bring in the caveat now. This does not mean that they will never get a seizure. And so we try to avoid the term cure. We try to avoid, we use more the terms seizure freedom, because sometimes even after several years, it can come back and it will necessitate the need for medication again. So when I'm meeting a patient who is starting on anti-seizure medication or anti-epileptic drugs, I usually counsel them that this is going to be a long journey. You know, this is a marathon, not a sprint. So we're thinking like Kemboi, not like Omanyala. And so they need to think about that and try to make the rest of their life not be affected by this, so that they're not spending too much time thinking about how soon will I get off this drug, because it can be frustrating.
Thanks. I think that's very clear. That's usually a difficult question. Now, I think tied to that, somebody had asked about availability of EEG in the, I think he put a question quite generally, but you've responded. I mean, we have had an EEG in Kenyatta not functioning for quite some time. There are renewed efforts to have this up and running. I'm aware that this is in the process of procurement, and hopefully soon it will be up. However, just to add that as far as diagnosis of seizure is concerned, we do not need an EEG to make a diagnosis of seizures, because sometimes people have an EEG. So somebody comes to you and says, I did an EEG and it's normal. I did a CT scan and it's normal. And so I don't think I have seizures. So I think it's good just to let everyone know that seizure diagnosis is largely clinical diagnosis. Largely eyewitness accounts. Sometimes, you know, I think somebody again asked about what we call pseudo seizures, then an epileptic, psychogenic and epileptic seizures. And usually now with the era of videos, one can be able to take this when somebody's having one, once they're comfortable, and could share with this with somebody who has experience in terms of looking at this and can be able to tell you where. So I think in terms of specific diagnostics, maybe we didn't quite go into that, but just to emphasize that the question of my EEG is normal, my CT scan is normal, so I don't have epilepsy, does not arise. So it's probably clinical diagnosis, likely. I don't know if Dr. Judy got another question. Dr. Magoha, did you? Dr. Magoha?
Yeah. Hello, can you hear me?
Yeah, I can hear you.
Oh, no, that's fine. I'm listening quite keenly. I agree with all of the statements my colleague has made. There's not much for me to add or to answer. The only one that I saw that was surgically related was whether or not we cause deficits when we decide on an operation. No, as I stated, with those 7 horsemen that we have, the 7 ZAS, with the 7 types of imaging that we do, we carefully select our patients. So it's not, we don't offer surgery to everybody. The only one that we can offer surgery without really thinking is messiotemporal sclerosis or a brain tumor. But all of those are different, and every brain tumor itself will act differently. So I think that's a point to note. But the most important thing, I think the take home here is to understand that for some patients, the surgeon will be involved. I think that's the most important thing. So, and we focus on removing the lesion or disconnecting some parts that are talking to each other badly. So if anybody can take that home, then I'm happy. Thank you.
Thanks, Dr. Magoha. I don't see any other burning unless Dr. Kwasa, you see any question you feel to respond to?
If I may, I was actually leaving this question to hear Dr. Magoha's take, because my take might be in the same line, but a little less surgically oriented. There's a question saying I'm a post-epilepsy patient, 12 years ago, hippocampectomy, went seizure-free for 4 years, but had recurrence and now on very high doses. I wanted to hear what you would say, Dr. Magoha, Because I think there needs to be some counseling that's done with these surgeries.
Yes, the counseling needs to be done. Even if the hypocampectomy was done, I would need to know the indication and what the follow-up is, number one. And number two, even if she has, he or she has seizures now, I don't know what the focus is. I don't know where the seizures are coming from. So we have to find that out. The issue is with base rate neglect, we'll always presume that it's the same thing that's happening or that it has failed. It could be something, or it could be something that was widespread before, or even something that she was born with, and as she grows, it starts to manifest. So there are very many reasons. I am not yet convinced that they're directly related. But as you've said, even though hypocampectomy was done, counseling should have been done first. And as I said, it's a multidisciplinary team. And as that big slide I put, surgery is not the end. I think people need to understand that. It's just one part of the tool, and we'd work with you and the rest of the team to figure that out.
Okay, thanks very much. I think we've exhausted what we consider to be quite cross-cutting concerns from our participants. I don't particularly see a specific question addressed to Ms. Kinoti, but thanks for the presentation. I think there's just one
Banus.
thing.
Dr. Ari,
Hi.
I was wondering whether Judy can help us for those who are primary care providers in level 1, level 2. What would you expect them to do? Level 1, level 2, level 3, what would you expect them to do in the context of epilepsy? You're muted, Judy.
You're muted, Dr.
Sorry about that. I think as Dr. Abwire had said, and as Dr. Magoha had said as well, epilepsy or a seizure can be diagnosed really just from history alone, luckily for a majority of seizures. So I feel like when we think in the context of level 1 and level 2, there is definitely a scarcity of resources, but epilepsy is one of those conditions that doesn't really need very much to make the decision to treat or not. And if you're convinced that this was a seizure and it's happened more than once and it's probably unprovoked, then we need to choose a drug. So the beauty is a lot of more of the traditional drugs are available at most of these facilities, and these would include drugs like at least phenobarbital, which luckily is used a lot in children, and so that would probably be a good drug to start. Phenobarbital, carbamazepine are available. And my advice would be, as you make that decision to start, remember, we start low and go up very slowly. So don't start 2 drugs at high dose, because those will be intolerable and your patient will not take the drugs, okay? Even though you're trying to to help them, it'll probably be intolerable. So my advice is be confident in your clinical ability to take a history and diagnose a seizure and its recurrence, probably unprovoked pattern, even in the absence of a CT scan or an EEG or any of those high-tech equipments that Dr. Magoha mentioned. Don't be intimidated. If you are strongly suspicious that it is a seizure disorder, start the medication, counsel the patient, pick a drug that you think will work for that patient. So remember, in women of childbearing age, we're avoiding valproate. If it sounds like it has a focal origin, like we presented in the case, then pick something with more of a focal origin preference, like carbamazepine, and continue these drugs and aim for, as best, seizure control, if possible, seizure freedom. I think that would be my advice.
Thanks, Dr. Judy. I think that we are in agreement with all of that. And I think sorry. Sorry about that. Yeah, we're quite in agreement with that. And I think that's sort of like the same practice. So I think we need to wind up this. Just wanted to mention something. I think Dr. Magoha had mentioned something about disability. It doesn't look like, I don't know if Dr. Judy has an idea if there are any rules about driving for, in this country for people who have seizures, license, suspension, anything like that. I've not come across that. Sometimes, of course, we get this and we discuss with the patients about their own risk and risk to other road users. But, sometimes, as we say, people are people, they'll still try out something, just a way to stop medication. So I don't know if Dr. Judy has any, or even Ms. Kinoche, an idea on whether we have any rules as far as that's concerned.
So I'm unaware of any specific legislation either prohibiting driving in this country, but like you've rightfully said, we do advise that if you've had a generalized seizure especially, then you should avoid driving for anything from 6 months to 1 year. There are other countries, like you said, that have specific legislation. Like I remember in the UK, you could not drive for 1 year, and it's not really to punish you, it's to protect you and other road users. I think it might have been around the same in South Africa, Dr. Obire?
Yeah, about 6 months in South Africa. You still with us? Okay, yeah, about 6 months. So thanks. I think with that, I bring this to the end from my side and hand it back to Dr. Eunice.
Thank you very much, Dr. Obire, for that perfect moderation. It's Friday, just to be able to go home earlier. And we do really appreciate our speakers. That was quite informative. Thank you, Dr. Judy, my classmate from Chiromo, Dr. Mike and Dr. Mary. The presentations will be provided. They've been recorded, so we can have Nelson, he's in IT at UoN-KNH, to confirm if they're available to us. Nelson?
Yes, this session, all of the sessions this week have been recorded and will be uploaded to our UoN-KNH website. If you wish to revisit them or rather rewatch them, you can visit the UoN-KNH website, and there's a webinars tab. And these presentations will be under UoN-KNH Symposium. Once you click on that, you'll be able to see the descriptions and the specific recordings for each day. Yes.
Thank you, Nelson. I'm now going to welcome Dr. Ojuka. He's going to give a vote of thanks and close the symposium on behalf of the of our dean, Professor Sanjo, who is out on official engagement. And Dr. Gata is going to bless us with a word of prayer after that. Welcome, Dr. Ojuka.
Thank you, Dr. Eunice, for leading us today. My name is Dr. Ojuka. I come from the University of Nairobi, Department of Surgery. We've been working with Dr. John Kinuthia from Kenyatta National Hospital in organizing this symposium that started from Monday on behalf of the university administration and Kenyatta National Hospital administration. We want to thank each and every one of you who participated, beginning from those who are participants, who have been with us from 2 to 5 each day, and all the panelists, beginning Monday, where we tackled the issues of diabetes, Tuesday, breast cancers, Wednesday, we handled hematological diseases, and yesterday we handled cardiovascular diseases, and today epilepsy. We really want to just say thank you, each and every one of you who prepared themselves and took their time to come and give knowledge, awareness, and way forward for the many issues that we have tackled. Of course, we have seen that there is increase in cases of diabetes, of hypertension, of cancers, of hematological diseases, of epilepsy, and even of the issues that we probably never touched on, mental health. And we have also seen that there are challenges in healthcare financing, in the inputs, in the professionals who may not know, who may know. And we therefore have opportunity as healthcare workers and as Kenyans to train in those specific areas, or to provide care, or to advocate. And there are many ways that we can do these things, so that as a country, there will be improvement in the outcomes of the management of the NCDs. And so I want to really thank the panelists for bringing this to the fore and helping us get this knowledge. Thank you again, the Secretariat, for working with us every day of the week, beginning in the morning and meeting the panelists. I am really grateful for Nelson and team, together with Meme and the rest of the Secretariat, who really have helped us across the week. Thank you very much. God bless you and have a great week.
Thank you, Dr. Ojuka. It's been great leading from you. We recognize the fact that here we also have patients and their caregivers. We want to wish you well and tell you that the healthcare workers are here to support you. I now welcome Dr. Gatia, who is the unit head of the Pediatric Dentistry and Orthodontic Unit at Dental School, to close with a word of prayer. Welcome, Dr. Gatia.
Thank you, Dr. Kihara, and everyone else. And good evening, everyone else. I was told to pray. Our dear Heavenly Father, we come before your presence this evening with thanksgiving in our hearts. We thank you for your goodness to us. We thank you for indeed we have enjoyed your many blessings unto us, and above all, the gift of life, which is so dear to all of us. And for this, we are thankful to you, O God. As we come to the close of this symposium, we want to thank you that it started with an idea which was worked on by the committee members who are the organizers of this symposium and research week. And we are thankful to you that, God, you helped them and you enabled them, you gave them the knowledge, you gave them the guidance, and you gave them the strength to continue to plan for this symposium that has really been wonderful. We thank you, oh God, that the panelists have really given us a lot of knowledge through the various presentations that have been there throughout the week. And we thank you because it is you who gives knowledge, and you give us knowledge so that it can be of help to us. And we want to thank you that you have enabled this and to us through this week, and how we pray that the knowledge that has been gathered by all of us, it shall go a long way to help us even in discharging our duties as clinicians, and even other areas where we serve the communities that have so much faith in us as they come to us, oh God, to seek help and to seek guidance when they go through the various challenges with their health. We pray, Father, that even the recommendations that have come up will find light and they will be implemented, Heavenly Father, that they may be used to guide and even bring down this burden of non-communicable diseases which are skyrocketing in this country. And we know that, Father, it is possible because you have given us the knowledge to work on the recommendations that have come up, and even to work with the knowledge that has been disseminated. And we pray, Father, that you help us, each one of us, to play our part so that we can work towards making the lives of ourselves and the people we serve better. We want to thank you, Father, for the committee, and we pray, Father, that you will bless each one of them, even for the time that they give of themselves. We pray for the presenters, that God, you shall bless each one of them, even as they give of their time to share the knowledge that they have. And we pray, Father, that you will continue to guide us as we serve in these institutions that, God, you have called us to serve. We pray, Father, that we shall be able to reach out even to the patients who come to seek knowledge and guidance and help. We thank you, Father, even for those who joined us, who are not caregivers. We thank you for them, and we pray that even as they go through the challenges they are going through, and even as they participate and work with the healthcare professionals in imparting knowledge to those who are going through various challenges with NCDs, that God, you guide them and that you bless them for taking that path of work, being co-workers with the health professionals. We want to thank you and we want to bless you, Heavenly Father, even as we pray that you bless even these two institutions we join together, the Kenyatta National Hospital and the University of Nairobi. We pray, Father, that you bless those institutions and that God even bless all the workers who are working in them. Father, as we come to the close, there is a weekend ahead of us, and we pray your blessings upon every one of us, that God, even those who have been tired, that God, you will refresh them, and that God, they will find strength once again in you, dear Father. We want to thank you as we pray that you dismiss us with your blessings, and may we continue to enjoy your goodness to ourselves and our families, and even to our fellow colleagues. We thank you and we bless your name as we pray this in Jesus' name. Amen.
Amen. Thank you, Dr. Gatia, and the close to 500 participants who waited patiently. Thank you. Enjoy your weekend. Bye.
Thank you.
Bye-bye.
Thank you.